Hi, I'm Emily Previti, and this is Folo PA, the Pennsylvania Capital Star's podcast focused on policy affecting Pennsylvanians, featuring audio journalism that emphasizes context, accountability, and community impact. The Commonwealth expects to get nearly $1 billion over 5 years through the federal Rural Health Transformation Plan. Some of that money will go toward launching the state's Primary Care Medics Initiative. The goal is to have trained medical professionals making house calls to triage care, helping to extend the reach of doctors in rural communities, where they're in short supply, on top of, and in some cases tied into, other health disparities in these areas. My colleague Whitney Downard is getting in on the ground floor with her reporting on this program, which isn't expected to begin until 2028, and we sat down recently to talk more about it. Whitney, thank you so much for making the time to be here.
Thanks for having me. I'm excited to be here.
Before we get started on primary care medics specifically, can you share a bit about your background with our audience? You really hit the ground running as soon as you arrived in Pennsylvania several months ago, and you have what seems like a really fantastic basis for comparison for your reporting because you've lived in a few other states in different regions of the country too. So Utah, New York, Mississippi, and most recently Indiana, correct?
Yes, I consider myself to be an upstate New Yorker, but I just moved here from Indiana 8 months ago, almost 9 months ago. And so I have a lot of experience with health reporting in Indiana and Mississippi, where I've worked professionally, and it's something that has really drawn me in, and I've really loved to explore as I've progressed through my career.
You were working for our sister outlet in Indiana before coming to Pennsylvania, and so were you covering the State House as well in Mississippi, or?
Yeah, so in Mississippi, I wasn't a state reporter. I was in Meridian, Mississippi, which is a small city on the border of Mississippi and Alabama. And I did start kind of dipping my toes into health reporting. I was a general assignment reporter there, but Mississippi is one of the states that has not expanded Medicaid. And so I started doing some reporting on that. And that's when I realized, hey, I really like this topic. I really want to dive in more. So after Mississippi, I spent 6 years in Indiana as a Capitol reporter. First 3 for another outlet, and the latter 3 with the Indiana Capital Chronicle, which is the sister outlet for the Pennsylvania Capital Star.
So you are very familiar with having no shortage of stories to choose from while covering the Capitol, and it can be overwhelming sometimes. We ever pick our topics, to say the least, and there's a lot going on. So how did you find out about this Primary Care Medics Initiative? As we alluded to in the intro to the episode, it's not even launching for a couple of years. And then what about it got you interested in doing a story?
As I started my job here, I really wanted to connect with people to really learn about some of the issues and what they look like specifically in Pennsylvania. One of the unfortunate things about healthcare shortages is that we have them everywhere in this country and in pretty much every state, region, community, what have you, to some extent. Some areas are better or worse than others, but I was just meeting with some people, and I was meeting with some rural health researchers in Penn State, and they kind of mentioned this offhand, and I thought it was worth diving a little deeper into and using it to really launch into a really focused story on what are some of the solutions to rural healthcare that we are exploring in this Commonwealth, and what does it even look like on the ground in this state to not have access to a primary care doctor?
Right. And we're going to really unpack this, but it seems like such a simple, and that's what they say, right? The best ideas are often the simplest ones. And this seems like it could really be impactful across a spectrum of access issues and healthcare disparities. But one thing that is interesting, the initiative is modeled after the military's approach to medical care in combat situations. And can you tell us a little bit more about that aspect of it?
Yeah, so the doctor who I've been talking to about this, and he will be one of the first people to tell you that he's not the only person behind this initiative, but Dr. Mark Stevens with Penn State, he is a former Navy physician, and he said that for him it was really akin to what they call hospital corpsmen in the Navy. In the Army, they're Army medics. Other military branches have other names for this type of position, which is really just somebody who does a little bit of everything. They assist surgeons in the field, but they also are giving vaccines at clinics. But most importantly, they're not always working directly under or with somebody. They're always under the supervision of somebody, but they're not, the corpsman is who goes out with the battalion or the military unit and really is on the field providing that care, checking in on preventative care, water sanitation, all those little things. That is their job. Their job is to just really focus on maintaining the health of the troop on the battleground, on the battlefield. And whereas the doctors in the military are more in the back, taking care of people in the hospitals from a more safe distance. So that was the idea of having somebody who goes out, who isn't just stuck back at the hospital or at the clinic or doctor's office on the domestic side, and somebody who's out there in the community, going from place to place and really trying to deliver this care or some version of care, since a lot of primary care can be pretty routine, right where somebody lives or where somebody works.
Yeah, so I can see that solving a lot of access issues. One of the things that strikes me, and we know this from reporting, and there are other initiatives that have cited this when they incorporate home visits as part of the model for delivering healthcare. You don't know what you don't know, and I would think that there would be a big benefit to being able to see someone's environment in terms of how it informs your interaction with them, what kind of care you deliver, what kind of questions you might ask. So has the program architects talked about that aspect of it at all?
I've only really been able to do a few initial interviews. I think that they're still trying to figure out a lot of the smaller details, but I think the vision really here is if somebody is there giving care, they will have a better idea of what's happening with that patient than, say, if that patient is trying to do a telehealth visit. And that's one of the concerns, too, is that telehealth isn't really a great answer when these rural areas that don't have doctors are also the ones that don't have broadband connections or stable broadband connections. I've seen personally in my private reporting in Indiana, actually, with a mobile integrated health, which I think will kind of distinguish the difference between mobile integrated health and what this project plans to do. But it was a person who went to an elderly couple's home and was able to look and say, hey, those carpets are tripping hazards. Your washing machine is down too many flights of stairs for somebody of your age to go down. Let's revisit and rethink, how can we make this home environment safer for you so you can stay here and age here for much longer instead of tripping and breaking a hip and then having to go into rehab. Falls are one of the biggest reasons why somebody goes into a nursing home or other long-term care situation, and reducing that will reduce our overall health system cost.
Yeah, I can see that. So when we're talking about this program, it hasn't launched yet. What can you tell us about what the program envisions as far as maybe types of people who could be hired and what the training might look like to work in this capacity?
So one note I want to make about veterans who have been hospital corpsmen or Army medics is that the military doesn't give you a certification or any type of stamp saying, hey, you have this medical training that transfers back home. So if you are discharged, you kind of have to start fresh even though you have all this medical knowledge that you could be putting to use here back home. So it's been really hard for a lot of veterans who do have this type of training to find a path. A lot of them try to become EMTs or paramedics because that's kind of the closest equivalent we have, but that obviously has a transportation aspect embedded into it and isn't the same as that primary care aspect that they're trying to deliver here. But really the emphasis wants to be on people who are already in these rural communities, because research tells us that people who are trained and already live in these rural communities are more likely to stay there. One of the problems we have is that we train medical professionals and then they all cluster into the big cities or dense populated areas where there already are some people serving this position or serving in this capacity, and they're not going out into the communities and kind of spreading. So I think that the focus is going to be a lot on recruiting people who are already in these rural communities with these shortages. And they don't necessarily have to be new high school or college graduates who are trying to explore the medical field. It really can also be somebody who is already a community health worker but wants to try something new, or even a upskilled health worker, maybe a physician assistant, a nurse practitioner, a doctor who wants to maybe transition down after working and maybe wants something that's a little less intense but still gets them out there in the community. So I think that's the hope for what type of recruits might be best to serve in this capacity.
Yeah, and I did not know prior to reading your story that military medics don't have any kind of credential after they've done that work, which seems hard to fathom. And then the statistic that you had was conservatively 2,000 people leave military service every year who've worked in that capacity. So is there any history or track record of efforts to change that, or was that ever different? What did you learn about the backstory there?
Actually, this is one of my future stories that I'm really excited to dive into a little bit more, is specifically about this population. From what I understand, a few other states have better programs for really transitioning somebody into some similar type of role once they're stateside. Wisconsin was one of the ones that I heard, and I know that the VA actually has some programs for returning vets to actually start serving some sort of role, but it's not something that in Pennsylvania we've really specifically tackled. And that 2,000 number, I'll say, just came from a really interesting report that I read from a nursing master's candidate in California who was a former corpsman themselves and was trying to figure out why are all these corpsmen not finding anything to do. One of the corpsmen I hope to interview in the future actually works at Amazon. So that's not a good use of their medical knowledge and talents when we have such a shortage here in the country and in this state.
Absolutely. So we've established that the goal is to extend the reach of doctors in rural areas where there's a shortage. And you touched on this, but are there specific types of cases or other health disparities that primary care medics seem like they could be especially effective at helping to address?
What I love about the name is that it's primary care medics. They're not just medics. And so I think the hope is really that they will stay in primary care versus other specialties like this that were pitched as a way to extend the reach of doctors like nurse practitioners or physician's assistants. But then those specialties started specializing in non-primary care roles. So I think the focus is definitely going to be on primary care, but I see this really being helpful with aging or somebody who has a transportation difficulty, somebody who is really isolated geographically, or even somebody who just physically is unable to come in for a doctor's appointment. And I also think that it helps with somebody who needs maybe some maternal care check-ins. Also, behavioral health is another one of the big ones that they want to focus on, trying to get just check-ins, assessing somebody, seeing if, hey, I can give you a really low level of check-in, but I really think you should prioritize finding some other help. But for now, this is better than nothing.
You've alluded to a couple of things that you're planning to delve into because this is a long-term engagement for you. You've published one story, but that's your early reporting. Your work on this is being supported through a fellowship, the National Press Club Journalism Institute's Public Health Reporting Fellowship, funded by the Commonwealth Coalition. So congratulations on that, on being selected.
Thank you.
And I mean, I think it's super interesting, and I'm excited to talk with you as reporting, but then read the stories as they come out. You mentioned a mobile health program in Indiana, but I'll ask if you want to expand on that or any other experiences.
One really big area I think that I wanted to focus on is aging too, because we are one of the oldest states in this nation, and those elderly Pennsylvanians are located disproportionately in these rural areas. Our rural areas have shrinking populations, especially young people, and those young people who leave don't come back, and then there is no population to really support healthcare services. And when I was in Indiana as well, I did a long-term project on nursing homes during COVID-19. So I really got to understand how many of the competing interests are working in this space. On the one hand, most people want to age at home, want to age independently, but to do that, you need support and services in your community. You need home health care workers who can check in on you. You need somebody who can deliver meals to you when you get to the point that cooking is difficult. You need these supports and community to really be able to enable somebody to live and age safely at home. But so many people don't have those and end up getting pushed into the nursing care system, which is a very necessary part of our aging infrastructure. But in the United States, we rely a lot on our nursing homes to adopt a lot more responsibility than they really can handle sometimes. And nursing homes too are struggling and closing. So it's giving less and less options for people. And I think this primary care program is part of refocusing and building up that care support infrastructure in a rural community.
It's good that you've had, like you said, that foundational or prior expertise developed already, so you can really build on it with this project.
I sure hope so.
Yeah, I'm confident that you will, Whitney. All right, so in other reporting, you've mentioned that the federal Rural Health Transformation Plan money comes with some strings attached. That plan generally, you've reported extensively on that already. And one of the caveats or criteria is that states are supposed to use the money for something new rather than continue or expand existing programs. And that does seem tough because you hear about initiatives all the time that seem like they're working, and then there's a concern about continuing because of funding. What is the thinking here? What has been articulated as far as why that's a requirement? And then based on what you know about the application process, were states getting theirs kicked back because their plans were not innovative enough?
Yeah, so I really want to add just a little background to the Rural Health Transformation Plan in the first place. It's a $50 billion plan that nationwide is sending out money to every state is going to get a slice of the pie. Pennsylvania's hoping it's $1 billion. If we are on track, we're going to get like a little less than $1 billion at this rate, but the hope is that those dollars can be used to start new systems and new ways of expanding healthcare, and cannot actually be used to just pay rural hospitals, for example, more money. Because the big concern is that with some of the cuts coming to Medicaid, that the rural hospitals will not be able to survive and will be shutting down. So the hope is that these dollars will do something new. And that's one of the criticisms of the project, that of the plan, is that they cannot go to bolstering those rural hospitals that are in desperate need of some support. But I want to say that states like Pennsylvania were very careful in their applications and really only included things that they knew they could deliver on. For example, the application process includes language that prioritizes states that have full practice nurse practitioners. Nurse practitioners in Pennsylvania must operate with an agreement under a physician, and Pennsylvania is not considered a full practice state since they can't be independent. And that's something that the state has been scrutinizing for years and years and years. And something like that was not included in our application as something we could change, even though if we had, we could have gotten more dollars. So I think that it wasn't so much that applications were rejected outright, but more that states were really intentional on what they did and did not include to make sure that they only included things that they could deliver on.
Picking up on that, Pennsylvania careful to pitch initiatives that would be successful here. So what does that mean? When the feds say deliver, do we know what that means in practical terms, and what might states have to demonstrate? So when Pennsylvania was really mindful of pitching something that would be successful, what would states have to demonstrate?
I think that's still a really open question, but I will say that Pennsylvania committing some of its dollars in such a way that it has to be documented and proven really showed me that the state believes that this program can work. The state believes that this can deliver in a really tight timeline. The first pilot is not even pitched to begin until 2028. And of course, these things take time. So I hope that nobody listening holds the state to that year because we don't know the specifics of that yet. But I think that delivering is really going to depend on how new rules come out, new guidance. I think the states are under a lot of pressure to figure out what and use a crystal ball almost to predict what people really want to see. Even though they've barely gotten their money, they're really soon going to have to put together a progress report, and then they have to start applications for the second year of funding formally. So I think that a lot of watchdogs are really worried that some states who are really stressed out are just going to put big chunks of money toward existing companies that promise they can do things and not really to the little guys who are trying to do something new and innovative. So it's something that we really need to watch closely. And I'm really hoping that since I have this fellowship and this time, I can just really analyze where we are now, how these dollars are going out, how we're prioritizing them. And I will, emphasize that people aren't that worried about Pennsylvania doing that big company promise. I think that the state is finding ways to help those federally qualified healthcare centers and those center lookalikes expand their technology offerings without having to go through a big corporation that is promising something different. I did want to note, too, that one of the additional pressures on the states is that this administration has shown it's not afraid to pull back on commitments. Dollars that were already promised to go to states for Medicaid have been clawed back. And so this is a lot of pretty stressful for states who are trying to figure out how to spend these dollars in a way that is both innovative and also abides by these kind of strict guidelines.
Yeah, we're familiar with that a little bit in the journalism world in terms of innovation is important, but sometimes it can seem like people are twisting themselves into pretzels to check that box to the detriment of continuing some things or supporting some things that seem to be working.
You're almost losing sight of your main mission in trying to do something, in trying to reinvent the wheel. And I actually got an email from somebody who was criticizing that, who said, why are we reinventing the wheel with these primary care medics? We already have nurse practitioners. We already have programs about mobile integrated health. And that is something I do want to dive into is what is the difference? Is this actually a new role that is necessary? Or is there a way we could have used this with existing resources? But again, this rural health transformation plan really emphasized new programs. And I think that this is a place that could really have the potential to deliver some really amazing results for people who need them.
Based on what I've learned through you and your reporting so far about this program, it seems like it walks that line that seems sometimes a difficult balance to strike. And then we touched on recruitment so far as the types of people who the plan architects are thinking they would recruit or that would be working in this capacity. So do you know anything more specifically about how they'll go about engaging them and then rolling out the program? I know that it's early stage, but with all the other stuff that you mentioned that has to happen bureaucratically and administratively, and the other initiatives that the Rural Health Transformation Plan money is going toward, apart from this, you need to start further out probably than one might think because of all of the competing demands on everybody's time.
Yeah, and you touched on this already, but one of the criticisms about any time you roll out a new plan is, how do we make this sustainable? How do we keep people in these positions and keep these people paid? I think that's a big question too, is what is the pay going to look like for this position? Is it something that is actually going to be attractive to people? A lot of the other healthcare positions we have in this realm are not very highly paid. EMTs and paramedics, we already have shortages of them, and their salaries aren't very high. So I think that that's one of the big outstanding questions I still have too, is about what the salary and pay is going to look like. It is more of an apprenticeship model. Instead of being you have to go to school for a set number of years and then do this, you get to learn as you earn. It is going to be through those federally qualified healthcare centers. Those FQHCs are going to be the ones who are overseeing these. And I think that with that hope is that there will be a built-in reimbursement structure, which is going to be very important for making sure that these positions get paid.
Are there any state laws or policies that you're aware of so far that might need to change to facilitate this program?
We actually don't give much support to FQHCs in the first place. As of right now, I'm not aware of any really specific rules that need to change to make this happen. There might be some sort of internal dialogue within the Department of Human Services to try to figure out what sort of licensing or certifications are accepted, and how that reimbursement structure will go with insurers. I'm not sure if the state legislature needs to do something now to facilitate that, but I do think that somewhere down the line, the state will probably need to revisit its commitment to federally qualified health centers and how those facilities really operate and whether or not they are getting enough money to really deliver. Right now, those are the facilities that are going to be connecting the dots, connecting these patients to these primary care medics. And without them, that the model won't work, because you can't just say any doctor can pick up a rural care primary care medic, good luck. You really have to train a doctor on what they are capable of and what they can do and make sure people are familiar with it. So I think that is going to come back up. And maybe, like I said, the state is able to just dedicate some of those rural health transformation dollars to this and really shore up those services, which they're very vital because they're in these rural communities. And I think we have just under 50 of them in the Commonwealth. And that's the only thing I can think of at this time that will probably need to be revisited in the future.
Along those lines, your story includes a call for experiences with rural healthcare access. What has the response been like?
I've had a few people reach out and really tell me about specifically the hospital closure in Bradford, which is in the northern part of our Commonwealth in McKean County, actually very close to where I went to college in St. Bonaventure. Go Bonnies. And so that hospital closing has really left a hole in access for that community. And it is one that I hope to visit and talk to some of the people about how their lives have changed since that hospital closed and what it really means to a community to lose a cornerstone like that. Unfortunately, we've seen that in several communities around the Commonwealth. But I also want to visit places that haven't had a hospital for quite a while, and maybe having a rule-based program like this could really just extend the reach. I do want to add that the state is also spending some of its rural health transformation dollars on a new doctor training program at the Indiana University of Pennsylvania, an osteopathic school of medicine. So this is not the only thing we're working on to try to train up more rural-focused healthcare providers, but I do think that this one might be able to have an easier onboarding. This one might be a little easier for people to access since it requires less training than a med school does. And anybody who has a rural health story or access issue that they want to talk about can reach out to me. I'm still planning where I want to go. So I would really love to hear your story and talk a little bit more about what it could mean to have just a little bit more of a safety net. Email's the best way, wdownard@penncapital-star.com.
And we will put that information in our show notes as well. Well, thank you for making the time.
Yeah. Let me know
Thank you for listening to Folo PA, the Pennsylvania Capital Stars podcast focused on how policy affects Pennsylvanians, featuring audio journalism that emphasizes context, accountability, and community impact. You can find us wherever you get your podcasts. And if you like what you've heard, we'd love it if you'd recommend it to a friend. To stay updated on the latest episodes and other work by our team, you can subscribe to the Capital Stars newsletter, The Morning Guide, at penncapital-star.com, and we've included that link in the show notes. Our theme music is Dusk by Mr. Smith, courtesy of the Free Music Archive, licensed under an Attribution 4.0 international license. Folo PA is edited by the Capital Stars Editor-in-Chief Tim Lambert, and hosted and produced by me, Emily Previti. Thanks again for listening.